Hello, good evening, all young intensivists and students and friends from different specialities. Today, on our Critical Care Sunday webinars series, we have a case presentation from Apollo Gleneagles Hospital, Calcutta. So, the case is one of post-renal transplant patient with severe diarrhea and multi-organ dysfunction. The case has been moderated by Dr. Samjogita, who is a consultant in critical care in that hospital, and will be presented by Dr. Debanjana, who is a second year DNB student in critical care. And joining us along with her will be Dr. Promita. She's also a second year DNB student. And we thank Dr. Chandrashir Chakravarti, who is senior consultant in that hospital, for making this possible, though he'll not be joining us because of some other issues. So we will be happy to take any questions at the end of it. You can post them in the chat box. We are live on Zoom and YouTube. Over to you, Dr. Devanjana and Dr. Promita.
Good afternoon, sir. Today I will be presenting a case of post-renal transplant diarrhea with MODS. A 42-year-old male with a background of IgA nephropathy, post-allograft renal transplant 1 month back, type 2 diabetes mellitus, hypertension, chronic kidney disease, and hypothyroidism, presented to the ER with loose motion for 7 days, shortness of breath for 2 days, abdominal distension, decreased urine output for 1 day. There was no history of fever. The ongoing medications he was on is Septrin DS, Eltroxin, pantoprazole, Visolon 5, mycophenolate mofetil 360, rifaximin, tacrolimus, and valganciclovir. On presentation to the ER, the patient was drowsy but arousable.
Just go back in the history, Dr. Devajana. Now, I would like to know, very important is how much was the loose motion? That is very important. You have to quantify the loose motion. How bad was the loose motion?
So, voluminous loose motion around 6 to 7 times per day. It increased. It started with 4 to 5 times. It increased to 6 to 7 times, even to 10 to 11 times in the last 2 days.
That is very important in the history because that tells you the degree of hypovolemia that he might be having, right? So he has severe diarrhea. Yes. Fine. Also, I would like to know whether he has received any treatment because this has been going on for 7 days. Whether he has received fluids, whether he got any therapy, that becomes very important. What outside treatment has he got? Whenever you take the history, this is very important. What is the treatment he has got? Because many of them get shifted from outside, especially if they are coming to tertiary centers.
So initially he was not treated for first 2 to 3 days. He was not treated. They thought that it might be a for any medication side effect. But when the amount kept on increasing, I think there was a history that he took some local antibiotic. The name was not specified.
Okay, so there is not much treatment.
No, sir.
Did he receive any IV fluids? That is very important.
No, sir. He was not treated. No IV fluids, no in-hospital management, no intravenous medicines till he reached our ER.
Only oral fluid he was taking at home.
Okay. Now, why do you think he had loose motions? So, Dr. Devanjana, why do you think they were loose motions? What are the cause? What is the possible cause of loose motion in such a patient?
So in such a patient, first of all, we have to think about infection because he is immunosuppressed. Second, it can be due to this mycophenolate mofetil has a history of diarrhea, so that it can be because of that. Other than that, these are the 2 things that I was thinking, sir.
Okay. So you are saying infections because of immunocompromised. So can you get any other infections? One is infections in immunocompromised patients. So they are different from the usual infections, right?
Normal infection also he will be prone to.
Yes. So he can have, because season is also, rainy season, he can have. These patients can always get community acquired infections also, which you usually get as a cause of infective diarrhea. Second, you have rightly said mycophenolate can also cause diarrhea. Any other cause? So, Promita?
Sir, non-infective causes, maybe they are in immunocompromised patients like graft versus host disease, mucositis.
Very good. So that's excellent. Graft versus host disease can also cause diarrhea in such patients. Okay. Now, those are the causes of diarrhea. Now coming to abdominal distension, why do you think is it usual for a diarrhea patient to get abdominal distension?
No, sir.
No.
So why do you think there's abdominal distension?
Sir,
One
sir,
thing is whenever you talk of abdominal distension, one has to be sure. Because if the patient is obese, then they also sometimes say there is abdominal, or you think there's abdominal distension, or the patient starts saying there's abdominal distension, right? Any patient who's obese will have a distended abdomen. So one has to be sure. So we assume there is abdominal distension, but what is the cause?
Sir, severe diarrhea. He was having severe diarrhea, and electrolyte loss was also there. So hypokalemia may cause ileus, and abdominal distension may be
I
there.
agree. Okay, hypokalemia can cause abdominal distension. Anything else?
Um,
Can it be anything related to the graft, any anastomosis? Though kidney transplant, I don't think much of it, but still any anastomotic leak, any localized collection,
Yes.
which is irritating and causing diarrhea and
Okay.
distension.
So one person has commented C. diff. So it's possible severe C. diff infection does lead to abdominal distension. So abdominal distension we'll discuss further. Then potassium is a possible cause because hypokalemia can occur because he's having severe diarrhea and there is significant potassium loss in GI losses. Okay. Now coming to SOB. When a person is admitted to the ICU with SOB, what are the systems which are generally involved?
respiratory system.
So Devanjana, you can also answer.
Metabolic.
Anybody you can answer.
Oh, okay, sir. So person when he is coming to the SOB, sir, there can be to an ICU. Sir, there can be multi-system involvement. First, since the person has SOB, the LRTI, the respiratory tract infection has to be thought about. Second, in a patient with abdominal distension with obese patient, that can also cause to a SOB. Third is severe metabolic acidosis, again is a cause of SOB. And fourth, any infection, any sepsis, that also can cause SOB because of ARDS.
Okay. So any other system can cause? You have missed one system. Very good.
Heart.
What you have said is right. All are right.
Heart.
Yes, one very important to remember acidosis.
Cardiovascular system, yes, sir,
Cardiovascular.
cardiovascular system.
Yes.
Cardiovascular
Heart
system.
failure,
Yes, heart failure is very important and acute anemia, severe acute anemia. That is also
yes,
very
anemia,
important.
yes, sir.
Sometimes
Yes,
patients
sir.
start bleeding, drop of hemoglobin. They can also develop anemia, shortness of breath on walking and dyspnea on exertion. And acidosis
Yes,
is
sir.
very important. Severe acidosis also leads to shortness of breath. And
Yes, sir.
a patient whose diaphragms have gone up because of abdominal distension will also cause dyspnea, but that will not be so much severe. So I agree with all this you have said. Now coming to loose motions and abdominal distension. So we have discussed the causes. Is there anything else? Any non-infective cause or any other cause that we other than what we have discussed, which can lead to loose motions and abdominal distension in a patient who's diabetic, hypertensive, probably has atherosclerotic disease?
Yes, sir. Autoimmune,
Ischemic-
autonomic dysfunction may cause that.
Now, how will autonomic dysfunction cause?
So autonomic dysfunction may cause loose motion.
No, you can get loose motions in severe long-standing diabetes because of autonomic neuropathy, but that is not a severe kind of a diarrhea. It comes and goes. That is not the answer here. I have given
Sir,
you
ischemic colitis may be.
yes. So not ischemic colitis exactly. Is acute mesenteric ischemia. Acute mesenteric ischemia is another possibility. Yeah. So acute mesenteric ischemia can lead to abdominal distension because it leads to peritonitis and ileus. But the only thing is, loose motions don't go on for 7 days. The usual course will be more severe and shorter. The patient will deteriorate faster. So that
Yes,
is another differential diagnosis, especially considering he's diabetic hypertensive. So he's prone to atherosclerosis, acute mesenteric ischemia. Okay. In acute mesenteric ischemia, what test rules out acute mesenteric ischemia? Any blood test?
Lactate level should be very high.
Lactate level rules out or rules in?
Rules, if the lactate level is very high,
In acute mesenteric ischemia.
Sorry?
Yes, sir.
What is the relation between lactate and acute mesenteric ischemia?
So disproportionate increase in the lactate.
Not disproportionate. It is a cause of unexplained lactic acidosis. Unexplained lactic
Lactic
acidosis.
acid.
So if you have, because you see acute mesenteric ischemia is a condition in which there is pain, but very few physical signs and symptoms.
Yes, sir.
And if the patient develops it under sedation or when he's mentally operated, you won't really get anything, because the examination will not tell you much, and he won't complain of pain, and especially if he's immunosuppressed or elderly.
Yes, sir.
Okay, so that is acute mesenteric ischemia, but lactate levels are elevated in only 80%. In 20%, you can get acute mesenteric ischemia with normal lactate. The test which actually has more specificity is D-dimer. D-dimer, if it is negative, almost rules out acute mesenteric ischemia. D-dimer, 95% negative predictive value. So that is another consideration here. Okay, I think we shall move on. It is, you have seen the immunosuppression he's getting. He's on Visalon also. So if the patient is on Visalon, what happens with the secretion of cortisol?
The cortisol will be suppressed.
Yes, so Visalon, if a patient gets more than 7.5 milligram prednisolone for greater than 3 weeks, his endogenous cortisol is suppressed.
Yes,
Okay,
sir.
and when there is acute illness, when there is an acute illness, there has to be an increase in the dose of exogenous cortisol. These patients
Yes,
have
sir.
to be given exogenous cortisol because they cannot mount their own response. So this patient who has been ill for so many days should have been on an increased dose of Visalon.
Yes.
This is a relative adrenal insufficiency,
Yes, sir.
Yes, sir.
which may be contributing here. Okay, let's move on.
So the next slide, sir.
Yes, this one.
On presentation to the ER, the patient was drowsy but arousable with a GCS of E3, V4, M6, no focal neurodeficit, heart rate 104 beats per minute, respiratory rate around 34 beats per minute, BP was not recordable, saturation was 100% on BiPAP with 100% FiO2. His body weight was around 90 kilos, height was 160 centimeter, CBG 353 with an urine ketone negative. On examination, the chest had bilateral basal crepes, CVS S1, S2.
Next slide. You have to move to the next slide. Yeah. So
On examination, the chest had bilateral basal crepes. CVS, the S1 heart sounds were audible, no added sounds. Tachycardia was there with a very feeble peripheral pulse. Abdomen was distended, soft, non-tender with a very sluggish IPS. And right flank suture site was noticed, which was healthy and dry and non-tender.
okay. So go to the previous slide.
Yes, sir.
So here the BP is not recordable. He's drowsy. Okay, and he's been put on BiPAP, and body weight is 90 with a height of 160. So is the patient obese?
Yes, sir. The patient was obese.
When do you say the patient is obese?
BMI
So the
was more
BMI
than
is
30.
more than 30.
Very good. BMI more than 30 is obesity. So
Yes, sir.
many trials have shown that compared to the outcomes in obese patients vis-a-vis patients who are non-obese with the same degree of critical illness. So what is the outcome in obese patients compared to normal patients with critical illness? Is it better, same, or worse?
Better.
Huh?
Better.
Better? So Dr. Devasys has said better. So why is it better? Is it better? Everybody agrees. Dr. Devajana, you agree it is better in obese patients?
I don't know.
So this is known as the obesity paradox. Obese patients tend to fare better with the same degree of criticality in the ICU. Read about it. There are reasons given for this. It is known as the obesity paradox.
Okay, sir.
Okay. So now heart rate is 104 and the patient, the BP is not recordable. Is the heart rate commensurate with the blood pressure? Not being recordable. He's in frank shock. Okay, he's altered ventilation, there's no urine output. So there's an end organ impaired perfusion.
Yes, sir.
It's not recordable, so BP is very low.
Yes,
The
sir.
heart rate is 104.
Sir, the patient was already on ivabradine 5. I do not know. Maybe that may be a contributory
He was on
factor.
ivabradine. You didn't mention that in the
Yes.
drug history. So
Oh, yes, sir.
you should always mention, this is very important. Previous drug history is something our residents don't take in all that detail. You have to be very careful. What drugs he's taking, what treatment he has received from outside, what background illnesses he has. This is very, very important. Half the solution lies in all this. So that's what I told you, that there's a problem here. The 104 heart rate is not commensurate with what he's having. So he's on ivabradine. Huh?
Yes,
So
sir.
can you have sepsis with without tachycardia? Sepsis
So if
of-
the patient is on beta blocker or ivabradine, something like that, it can be
there
unmasked.
is no
Otherwise, it
drug.
should be there.
If there is no drug, then
It should be there, sir.
so Pramita, what do you think? Can you have septic shock without tachycardia? Paramita?
Sir, in the diagnosis of Q score, there is no point in tachycardia. There is a hypotension, the altered mental status, and tachypnea. This 2 out of 3 criteria can be positive. Without tachycardia, we can also say that the patient can have septic shock.
Yeah, that is true. But the question is whether tachycardia, it is not necessary as per the definition, right? There is no definition. What is the definition of septic shock or sepsis? What is the definition of sepsis?
Sepsis is
Life-threatening
defined as
dysfunction.
One minute, Paramita.
sepsis is life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock is a subset of sepsis in which the circulatory, cellular, and metabolic parameters are deranged enough to cause increased mortality.
So
Clinically,
sepsis is life-threatening infection or something else?
life-threatening organ dysfunction
Organ
caused,
dysfunction.
caused by
Organ
dysregulated.
dysfunction. No, one second. Organ dysfunction is defined as life-threatening or something else. It is not defined as life-threatening. You should know the definition of sepsis. It is increase in SOFA score by 2.
That is also there. So,
So you have to quantify. Life-threatening is what is life-threatening? It is an organ dysfunction. SOFA score increase in 2.
increase in 2.
At least 2.
Yes, sir.
Huh?
Yes, sir.
Increase in SOFA score of 2 is quantification of the severity of infection.
Yes, sir.
That is very important.
Hmm.
Suspected to be because of an infection.
Hmm.
The definition has to be known. It is very important. No? So, is lactate necessary? Elevation of lactate necessary for the diagnosis of septic shock? As per the latest guidelines. Guidelines were published 1-2 years ago, right? The last surviving
Yes.
sepsis guidelines. Is elevation of lactate necessary?
Yes, sir.
So lactate more than 2 is contributory.
Is it necessary for the diagnosis of septic shock? Can you diagnose septic shock if lactate is normal?
Yes, sir. No, sir. Sir,
No, sir.
lactate more than 2 is suggestive by contributory to septic shock.
Lactate is not necessary anymore for the diagnosis of septic shock. Okay, it has been removed from the guidelines. So 10%, around 10% of the patients who have septic shock have normal lactate levels. And these patients, the prognosis is generally much better.
Okay, sir.
Is procalcitonin necessary for the diagnosis of septic shock?
No.
No, sir.
It is not necessary. So that is very important. Okay. Now there is hyperglycemia. He is diabetic, but these sugars are very high. So why do you think the sugars are so high?
Due to infection, sir.
Meaning what?
So infection causes an increase in stress response, which causes an increase in glycemic level.
Okay, fair enough. Urine ketones are negative. Okay, next slide. Now about the tachycardia, I would like to say about the tachycardia, the heart rate in sepsis. So sepsis will always be having tachycardia, except if there are drugs or there are associated conditions. For example, elderly patients. In elderly patients, there may be sinus node dysfunction. Okay, so they are unable to mount a tachycardic response. You understand? There may be sinus node dysfunction, or the patient may be hypothyroidism, like this patient. So the thyroid may not be under control. He may be having hypothyroidism. So again, there won't be that much tachycardia. So unless there are underlying diseases or incompetence, chronotropic incompetence, they will always have tachycardia. Rarely viral sepsis may also not have tachycardia. Otherwise, usual bacterial sepsis will have tachycardia. It is an important feature. But most of the patients who come with shock and bradycardia are usually on beta blockers or calcium channel blockers. The commonest cause of relative bradycardia in patients presenting to the ICU is beta blockers. Okay, so now he has basal Krebs. So what is the cause of basal Krebs here?
Probably basal lung collapse because of abdominal distension. The patient had high PF ratio also, so probably basal lung collapse. LRTI there was no features of LRTI, sir.
What do you mean there were no features of LRTI?
Sir, there was, sir, because I know about the patient, that's why. From the history itself, it can be LRTI because of LRTI also.
No, Devanjana, why are they basal Krebs? On the basis of history and examination, whatever you have seen the patient. One you have said there can be because of abdominal distension. There can be basal atelectasis. So I
Yes,
agree
sir.
with that. Anything else? PF ratio was decreased.
Yes, sir.
So what else?
So probably sepsis-induced ARDS.
So sepsis-induced lung injury. Huh?
Yes, sir.
That is also possible. Huh?
Yes, sir.
And aspiration? You are drowsy?
Drowsy, yes, sir.
Huh? And he could have had pulmonary embolism also. That will
Yes,
lead
sir.
to bilateral crepitations, basal or not?
Yes, sir.
Sir, generally, pulmonary embolism should not lead into bilateral basal.
Yes, it will not lead to generally. That's correct. So possible, most likely, basal atelectasis, maybe acute lung injury due to sepsis. We don't know. Huh?
Yes, sir. Yes,
PF
sir.
ratio was how much was the PF ratio?
So initially it was around 200.
200 in
Over
the
here,
IC.
sir, on 100% FiO2, the PO2 was 160.
Okay, we
The
will see
PF
that
ratio
as you carry on. We will see that. So this is the ABG, huh?
Yes,
yes,
sir.
sir. So the PF ratio was around 160, sir, with 100% oxygen.
No, the on 100% oxygen.
Yes, sir.
No, that was on the ventilator or what?
So on BiPAP, the patient was on BiPAP.
Ah,
Because the patient was dyspneic on the ear itself, they put him on BiPAP with FiO2 100%. And so the ABG was taken after that.
okay. So does shock have any bearing on PF ratio? Hypotension? If the patient has cleared lungs and has severe shock, will the PF ratio decrease? Pramila?
Yes, sir. Maybe
It decreases.
it decreases.
Severe shock is a cause of decreased PF ratio because of ventilation perfusion mismatch. Because there won't be adequate perfusion.
Yes, sir.
Yes, sir. Perfusion is hampered and
Yeah. And it also elevates the CO2 also. If it's extremely severe, extremely low cardiac output states can elevate the PCO2 also.
Yes, sir.
With normal lungs. Remember, severe shock, severely low cardiac output can cause hypoxemia as well as hypercapnia.
Yes, sir.
Okay. So what is the ABG diagnosis here, Dr. Devanjana?
So the pH was 6.886 and the lactate was 3.3 with a PCO2 of 12 and bicarbonate of 8. So, sir, we were thinking it's a severe metabolic acidosis. And the chloride was 130 and potassium 105.
Oh, there is
So,
metabolic acidosis. Huh?
yes, sir.
What about the,
Uh,
you cannot answer like this. You have to tell the full ABG. Where is the compensation?
Sir, the PCO2 was 12.
See, when you
So-
answer the ABG, you have to be very careful. You have to give the complete diagnosis. This is a very important ABG. pH is only 6.86. He's going to die almost. Tell the full ABG diagnosis. Whatever you can tell on this ABG. There's a lot of information in this ABG.
30 minus 105 plus 8, 20, 13. So it's a, sir, high anion gap metabolic acidosis.
High anion gap, metabolic acidosis.
Metabolic acidosis.
How do you
Yes, sir.
calculate anion gap?
So 130 sodium minus chloride minus bicarbonate.
Bicarbonate.
Chloride plus bicarbonate minus that 130 minus chloride plus bicarbonate.
So how much is the anion gap?
So it's coming 130 minus 105 plus 8 is 113. So it's coming around 17.
What is normal anion gap?
12 plus minus.
Around 10. 10 to
12
12.
plus minus.
We take it as 10.
Yeah, 8 to 12 for calculations you may take it as 10. And
Yes.
you are not corrected for albumin. You should
So
correct
albumin is
albumin.
3.2. Albumin is 3.2. So it's
So what is the formula? You don't have to correct. What is the formula for correction?
sir, 4 minus 3.2, that is 0.8. 0.8 into 1.5. 0.8 into 0.5, that is around 0.64.
No, 0.8 into how much? 0.8
Sir,
into
0.8, sir.
0.8 is the difference in the albumin. So it is to be multiplied by how much? 1.5 or 2.5?
So 1.5.
2.5. And that has to be added. Okay. Now you tell me about the this thing. You are not told me about the compensation.
Sir, from bicarbonate, we extrapolate to PCO2 to see the compensation. So the bicarbonate is 8.
No, you tell me what is happening here.
So the respiratory compensation should be there.
No,
For to
is this you have to tell the full diagnosis. What is the ABC diagnosis in acidosis? What is the full diagnosis for compensation? See, if you have to answer, you have to answer. This is not, you're not answering the ABG properly. Paramita, you tell. What is the compensation here?
The patient is hyperventilating and CO2 washout is there to
no, bicarbonate
respiratory
calculation.
respiratory alcoholism. High metabolic acidosis, high anion gap metabolic acidosis with respiratory alcoholism.
1.5 into 8 plus 8 plus minus 2.
So anyone in the
Sir,
audience?
there is respiratory alkalosis also.
Hold on. Anyone in the audience? What is the ABG form here? What is the ABG showing apart from metabolic acidosis? Anybody in the audience?
Sir, there is respiratory alkalosis also. The patient should have the corrected. This is coming around 20 to 24, but PCO2 is 12. So there is associated respiratory alkalosis also.
What is the expected PCO2 here?
So expected PCO2 is around 20 to 24.
20 to 24. How do you
So
calculate?
plus minus 2.
Yeah, so how do you calculate that?
So 1.5 into absolute bicarbonate plus 8 plus minus 2.
Sorry? Again?
So 1.5 into bicarbonate plus 8 plus minus 2.
Okay, so how much you get? 1.5 into 8 is 12.
12 plus 8 is 20.
Okay.
So 20 to 24.
Okay, what is this formula called?
Sir,
It's called Winter's formula.
Winter's formula.
I forgot
Winter's
the name,
formula.
sir.
It's okay.
Winter's
So
formula.
you are getting PCO2 of 12.
Yes, sir.
So there is respiratory alkalosis.
Yes, sir.
It's very important. Severe metabolic acidosis with respiratory alkalosis. If you don't tell respiratory alkalosis in this, it is not correct to say this in the APG. You have to mention the complete diagnosis. Metabolic acidosis is very obvious, but you have to apply the formula for compensation. You can see the PCO2 is only 12.
Yes, sir.
Okay. Now, you told me about anion gap. Anion gap is elevated. So there is anion gap acidosis. So what are the causes of anion gap acidosis here?
Sir,
Lactic
lactate
acidosis.
3.1, that can is contributory. And because the patient is anuric, that can also be the uremia can also be contributory.
So renal failure and lactic acidosis.
Yes, sir.
Huh?
Ketones was negative. Urine
Yeah.
ketones was negative, but beta hydroxybutyrate acid was not done till then. So
So what are the causes of high anion gap acidosis?
Ethylene glycol, methanol poisoning, ketoacidosis. Sir, any kind of ketoacidosis, then methanol poisoning, ethanol poisoning, renal failure, uremic rhabdomyolysis, and
paracetamol toxicity.
paracetamol toxicity,
Sorry,
salicylates.
No,
toxicity.
One person speak. Paramitas, there are 4 main causes only. What are these?
Sir, ketoacidosis, diabetic ketoacidosis or starvation ketoacidosis, anything. Then methanol and ethanol toxicity may be there. Then renal failure causing uremia. Then salicylate toxicity is also there.
Okay. So you remember like this, there are 3 causes mainly: uremia, ketoacidosis, and renal failure. But
Renal failure.
these are 3 main causes. 4 causes poisonings, many poisonings.
Many poisonings. Yes.
Methanol, ethanol, salicylate, whatever.
Okay, sir.
Other poisoning also, which are not so common. So there are only 4 main causes. In the ICU, renal failure,
Renal failure.
ketoacidosis, and lactic acidosis. Okay. Now, Devanjana, is the lactate of 3 compatible with lactic acidosis? A serum lactate of 3, is it compatible with acidosis? Do you usually get acidosis in the lactate of 3?
No, sir.
No,
Yes,
sir.
it is not common to get acidosis with a lactate of 3. It's only as the lactate level goes higher, we get acidosis. So
Yes, sir.
one cause is renal failure. Maybe lactic acidosis also is difficult to say. It can happen, but usually it's only with moderate or severe lactate elevation you get acidosis.
Yes,
And
yes, sir.
any other cause for acidosis here? One is renal failure, maybe lactic acidosis. Any other cause? Very obvious. What is the primary disease?
Renal failure.
IgA nephropathy.
No, IgA nephropathy, the patient is transplanted now. What is happening to the patient?
In sepsis.
No, where is the evidence for sepsis? How does sepsis cause by lactic acidosis or renal failure? Sepsis per se is not the cause. Patient has diarrhea.
Diarrhea.
H plus.
Patient is having severe diarrhea.
Yes, sir.
So what kind of acidosis you get with diarrhea?
Generally non-NM
Non-NM
metabolic acidosis.
Huh? Non-anion gap.
Usually nagma is associated with diarrhea, sir.
Non-NM metabolic acidosis.
So he has diarrhea because of 2 reasons. One is renal failure. Second is severe diarrhea, which is non-anion gap metabolic acidosis. And maybe some degree of lactic acidosis.
Yes, sir.
Okay,
Yes,
now, when you get such severe diarrhea, why is there so much acidosis? The diarrhea?
The loss of H plus and
Loss of?
H
so loss of H plus ions and so
Not loss of H plus ions, loss of alkali. Diarrhea is rich in alkaline fluid and potassium, especially colonic diarrhea. Huh? So they lose a lot of alkali and they lose a lot of potassium. That is why you get acidosis. It has high alkaline content and high potassium content. Huh? So, is there any way you can make out whether this patient has normal anion gap acidosis also?
Yes, sir. Gap. We take this gap ratio.
Very good. Excellent. So what will happen in that?
Sir, we take the anion gap and divide it by the bicarbonate gap. And if it is less than 1, it's high anion gap plus normal anion gap metabolic acidosis.
Okay. So you take the ratio of?
So, high anion gap by bicarbonate gap.
Bicarbonate by bicarbonate.
Only one person should speak iodide too, otherwise it gets confusing. So if it is only lactic acidosis, then what will happen? Or if it's only renal failure, then what will happen to the delta gap?
Only high anion gap metabolic acidosis will be there.
No, what will be the ratio?
1.
Delta Ag by delta bicarbonate ratio in
Less than
uremic acidosis or lactic acidosis will be how much?
So it will be
pure
less
high
than
anion
1.
of metabolic acidosis, it will be greater than 1, and in mixed, it will be less than 1.
More than 1 means
Devanjana, what will be the ratio in lactic acidosis or in uremic acidosis or DK? It will be 1 to 2. Huh? It is between 1 and 2. And what happens if there is a concomitant normal anion gap metabolic acidosis?
So it will be less than 1.
Yes, it is less than 1. Huh? So that is how you make out. So we will not do the calculations here because it will get difficult to do all the calculations. That is how you crack the ABG. So potassium is 2.3. So that is probably the cause of this abdominal distension. The potassium is very low. The sodium is also low. 130. Why is the sodium low? Paramita, why is the sodium low? So Dr. Saurav has said diarrhea. How did diarrhea lead to hyponatremia?
So hyperglycemia may be
So how does
because of sodium
hyperglycemia? What is the mechanism for
dilutional hyperglycemia?
Devanjana, how does hyperglycemia lead to hyponatremia?
Sir, there is dilutional hypernatremia.
Increase in sugar.
There is
retention of water.
Paramita, don't speak like that. You speak only if I ask you. So
Sir, the hyperglycemia causes
yes.
So the
Okay, it causes dilutional hyponatremia. Okay.
Yes.
What is the formula for seeing the true hyponatremia is there or not?
1.2 into this for every 100 increase in blood sugar, there is increase in 1.2 of sodium.
Above what
this
value?
decrease.
Above what value?
So above 200.
Above 100. Above 100 of blood sugar. So if now the sugar was 354, right? So what is the calculation?
So 254. So it's 1.2 into 2.5. It's coming around 5. So 130 plus 5 is 135, which is nearly normal.
So the correction is for you see how much sugar is elevated above 100 of blood sugar. And that much the correction is applied for every 100 into 1.4, not 1.2. That is the correction. Okay.
Okay, sir.
Okay, Devasis Ram, we agree with you. It is 1.4, not 1.6. Anyway, so now is there any other cause for hyponatremia? Suppose the sugars have gone down by now or something like that. Someone in the audience mentioned diarrhea. So does diarrhea lead to hyponatremia? Devanjana? You don't know. Paramita, diarrhea leads to hyponatremia?
Sir, it should bicarb loss is there, so
Bicarb loss.
No,
goes with
bicarb loss
sodium.
has nothing to do with hyponatremia. Bicarb loss will lead to acidosis.
So sodium with
Sodium.
bicarb.
No, bicarb has nothing to do with hyponatremia.
Usually diarrhea does not cause sodium
Huh?
loss. Unlikely.
No, diarrhea does not lead to hyponatremia.
Unlikely. Severe diarrhea. Maybe.
So Dr. Saurav said sodium-rich fluid. So Dr. Saurav, there is no body fluid which is hypertonic to plasma. Okay, there is no body fluid, including diarrheal fluid, in which the sodium content is more than plasma content. All body fluids are hypotonic. So if any loss is there from body fluids, it will lead to hypernatremia because water loss will be more than sodium loss. So diarrhea is a cause of hyponatremia, very common cause, because what happens is when there is diarrhea, you have losses of fluid which contains around 100 milliequivalents of sodium per liters, 80 milliequivalents, whatever, but it is replaced by hypotonic fluids. It is replaced by plain water. The patient tends to drink in plain water. So you get dilutional hyponatremia. That is the mechanism.
Okay, sir.
That is the mechanism. Very good, Dr. Devasis. So, is there any other cause for hyponatremia here? One more cause, someone in the audience has said already. So, he may be having yes, adrenal deficiency because he's on steroids. I told you in the beginning. And when the patient who's on steroids for a long time, more than 3 weeks, he goes into adrenal suppression. And he can have relative adrenal insufficiency in terms of critical illnesses because they require higher doses of steroids. So the doses of steroids have to be increased. So these are the possible explanations for hyponatremia. Okay, let's move on.
He was resuscitated with fluids around 1.5 liters.
Next slide,
early...
next slide, 1 minute.
The network is a little unstable. It's not moving. Slides are not moving, sir. Sorry.
You go back and move it, then yeah.
Yes.
Go full screen. Full screen, yeah.
Yes, sir.
He was resuscitated with fluids, normal saline around 1.5 liters. With early initiation of norepinephrine was done. Patient was intubated and mechanically ventilated. Blood cultures, urine culture, and endotracheal secretions cultures were sent. Comprehensive GI panel and CMV PCR was done. He was started on meropenem, teicoplanin, and metronidazole.
So, Dr. Devanjana, early initiation of norepinephrine is based on evidence or is it arbitrary? And why is it being done?
So the evidence is recent Clover's trial has said that early initiation of norepinephrine in a place which is not not so instrumental support without much instrumental support or technologically support that can have an increased improvement improved mortality.
So what did the
this
Clover's
case,
trial basically do? What was it? What is the basic element of Clover's trial? It was early initiation of NORAD and restricted fluids versus liberal fluids, right?
yes, sir.
So this is evidence based. There has been some other evidence also. So early initiation of norepinephrine helps to reach BP targets earlier, and that has
Earlier,
been effect. So this is based on evidence, and one of them is Clover's trial. Less fluids and early initiation of noradrenaline or vasopressors. Okay, very good. Now coming to cultures, you have sent all the cultures. Why stool cultures have not been sent? Should you send stool cultures?
Because we have this comprehensive GI panel where we get these things, where we get the probable cause of diarrhea, PCR. Yes, sir.
If you will you miss anything? If you said, is there any difference between stool culture and comprehensive PCR panel? What additional information will you get from stool culture, which you may not get from PCR panel?
Sir,
Anybody? Dr. Samjogita, you can contribute. You want to say anything on that?
Sir,
So you will get sensitivity. Suppose an organism is grown or identified by PCR. How will you know what it is sensitive to? He must have received a lot of antibiotics. He'll be harboring resistance. Supposing he gets E. coli in PCR panel, how do you know what is the sensitivity? You will not. You should always send stool culture. When there is severe diarrhea, you send the biofire PCR panel as well as stool culture and stool examination. For example, strongyloides. Strongyloides is a very common pathogen which disseminates in immunosuppressed. There is no strongyloides panel normally in PCR. That is done on routine OI examination. So it is very important to send stool culture and stool examination also. Basics should not be forgotten. PCR and all are good, but the basics are also very good. They have their own uses. One should not forget stool examination and stool culture sensitivity. Okay. Now you have started on meropenem, ticoplanin, and metronidazole. Now, why was you think ticoplanin is justified here in a patient with diarrhea and hypotension? What are the sepsis guidelines say for use of ticoplanin in sepsis? Have you read the sepsis guidelines published one or 2 years last ones? They have made some recommendation regarding ticoplanin use as initial antibiotics.
If there is risk factor for gram-positive organism, then we should only use gram-positive coverage only.
Okay, very good. So if you suspect gram-positive, otherwise it leads to worse outcomes. So
Yes, sir.
you get gram-positive organisms in diarrhea? What are the gram-positive organisms we normally get in the ICU?
Messaging resistant staphylococcus aureus. MRSA,
MRSA is one. What else is gram-positive?
Clostridium difficile.
What else?
Streptococcus.
Streptococcus is gram-positive.
Yes, sir.
So do staph and strep cause this thing diarrhea?
No, sir. But the patient was having shortness of breath, and initially we cannot differentiate what was the source of sepsis. So initially broad spectrum coverage is given.
If he's having so much diarrhea, then it is unlikely that the source is anywhere else.
Yes, sir.
If you have just one or two loose stools, you may get with any diarrhea as part of the prodromal symptom.
Yes, sir.
But when you have continuous diarrhea, 10 stools per day for 7 days and nothing else, then it is diarrhea. GI tract is the primary source.
Yes, sir.
So ticoplanin here is not justified really. I would not give ticoplanin.
Sir, one question. Since the patient is immunosuppressed and was recently had a renal transplant, so a flare-up of any gram-positive infection can also be a cause?
See, the problem is patient here has diarrhea. And diarrhea is not caused by staph and strep.
Okay, sir.
Right? If it was any other bacteremia, non-specific, it is justified definitely. Because you can have in the first 1 month, you can get infections from different sources, wounds and all that is there. And staph and strep can occur. But here your source is very clear. It is the GI tract. The patient has diarrhea. And diarrhea leading to so much of a problem is never caused by staph and strep. So ticoplanin is not justified. In fact, it can cause problems because if he stays longer, develops VAP and all, then already he will develop resistance. The surviving sepsis guidelines say that unless you suspect gram-positive infection strongly, do not give ticoplanin. It leads to worse outcomes. And in our ICUs, gram-positive is not common. Even in normal patients, we overuse ticoplanin. Any patient come into the ICU, we normally start on meropenem and ticoplanin. There is no indication to give ticoplanin, even if he was having something else. I mean, if he was not immunocompromised. There are very specific indications to cover staph. You should know the indications to cover staph. It's very important. Don't give ticoplanin. It is very common in the ICUs to give ticoplanin, and this comes from the West. Because all the Western literature says to give it. Because there the commonest organisms are gram-positive in their ICUs.
Okay, sir.
Okay. So what about meropenem? Now, this patient is immunocompromised, so he may be harboring a pathogen which is related to immunocompromised state, or he may be having an organism which is a usual organism which anybody can get, right? For diarrhea. So, what organisms normally cause diarrhea in a normal person who is not immunocompromised?
Sir, E. coli, Shigella,
Salmonella.
Shigella. What else?
Salmonella.
Salmonella. What else?
Vibrio
Viral
coli.
infections, rotavirus, norovirus,
Huh?
Virus is viral
adenovirus.
infection.
Okay, Salmonella, Shigella, pathogenic E. coli, huh? And there's
Yes,
some
sir.
other ones, Campylobacter, Yersinia, huh? Viruses.
Yes, sir.
So, is E. coli normally found in the gut, or is it if you grow E. coli in the stool, it is always pathologic?
Toxin producing.
So, anyone in the audience?
E. coli is a normal commensal.
Okay, so it is a normal commensal, and there are pathogenic commensals also. Okay, so you have to distinguish between the normal commensal and a pathogenic commensal. There are different kinds of E. coli. So when you get E. coli in the stool, it is you have to take the help of the microbiologist. Huh? Okay. Now, if you have a patient with diarrhea, infective diarrhea, so you're given metronidazole. Meropenem will cover some organisms. I'm talking about a usual patient because immunocompromised is not what we get. But sometimes normal patients come with severe diarrhea and hypotension and shock and all that. So one drug you'll give is metronidazole to cover amoebiasis, and giardiasis. Okay.
Yes.
Meropenem is a secondary drug. It is not that important for this thing, diarrhea. People sometimes give piperacillin and tazobactam. Is it a good drug for community-acquired infective diarrhea in a normal patient? It is not a good drug. Piperacillin tazobactam is not a good drug. Teicoplanin has no role. The most important drug, what is the most important drug we should give to a patient who's coming from the community with severe infective diarrhea and who is not immunocompromised?
So fluoroquinolones.
Very good. So there is increased resistance to fluoroquinolones now. So what is the other drug?
Ceftriaxone.
Ceftriaxone.
Cephalosporin.
Azithromycin.
Azithromycin.
Because this covers the other organisms you were talking about. So
Okay,
you see
sir.
the organisms which cause diarrhea are a little different. So you should give azithromycin, plus you should give metrogyl, plus you have to give a lot of drugs because these drugs have to cover all the organisms till you get a definitive diagnosis. Azithromycin, metrogyl, plus meropenem, plus possibly ceftriaxone, because you have to cover salmonella also. And there's salmonella paratyphi, there's salmonella typhi, they're different organisms. So you have to give different drugs. These are piperacillin tazobactam plus teicoplanin is not the answer for infective diarrhea. Neither is meropenem a preferred drug. So once in a while we get these patients who have severe diarrhea and who can create problems. And sometimes there's cholera also. You didn't mention cholera in the causes of diarrhea. What is the feature of stool of diarrhea, cholera?
Sir, rice water.
And how is it diagnosed?
Sir, motion in there's some.
How do you diagnose cholera? What test will you send for diagnosis of cholera? Dr. Pramita? Hanging drop.
Hanging drop technique.
So the audience is answering the questions. Okay. Now, what is the opening blood pressure?
Yes, sir.
What is the opening? You put in the arterial line. What is the opening blood pressure?
Oh, it's not written over here. Sir, they after on NORAD, the BP was NORAD requirement was increasing. So the when we did the outline, the BP was around 80/40.
Huh?
So after on norepinephrine support, the BP was around 80/40. Norepinephrine was initially started around 0.1 mics per kg, which was gradually increased.
BP was 80/40 when you put in the line. Huh?
Yes, sir.
And
Yes,
he was
sir.
already on NORAD.
Yes, sir.
Okay. So initially BP was non-recordable, then he was given some fluids, 1.5 liters, NORAD was started, and the line was put, and the blood pressure was 80/40.
Hmm.
Am I right?
Yes, sir. Yes, sir.
Okay. So next slide. So hydrocortisone and vasopressin was started, and patient was shifted to ICU. Okay. Next slide.
In ICU, the patient was sedated, ventilated on heart rate 123, BP 150/90, a saturation of 100% with 50% FiO2. Urine output was nil. Echo, which was done, showed 50% LV ejection fraction with mild generalized LV dysfunction. IVC was 7 millimeter, collapsed. Capillary refill time was more than 5 seconds. Temperature was around 97 degrees with cold peripheries. We gave sodium bicarb, sir, because the pH was 6.88 with bicarbonate of 8. Patient was, sir, next slide.
Okay, no, this slide only. So is fentanyl infusion a good choice here for sedation and analgesia? What is wrong with fentanyl?
So
Opioid
we've got
may cause
hypertension.
Sorry?
no. No, sir, fentanyl is an opioid. It may cause ileus. That may
Yes.
be.
So you should not give fentanyl. He has so
Hmm.
much distension.
Hmm.
So what you can give?
There is an option, sir.
What sedation can you give to this patient?
The dexmedetomidine.
Dexmedetomidine can be
Yes,
given.
you can give dexmedetomidine.
Hmm.
Sir.
Fentanyl opioids are known to cause paralytic ileus.
Yes.
What are the other causes of paralytic ileus apart from opioids and hypokalemia?
So urinary retention. Not in this case, but
Hmm? So other drugs also can cause like anticholinergics. Huh?
Hmm.
Retroperitoneal bleeds.
Deep collection abscess.
Huh? Peritonitis.
Yes.
You should know the cause of paralytic ileus. It's very important.
Hmm.
Sometimes the patient develop gross distension, Ogilvie syndrome. Okay. Now the heart rate has gone up to 123 within a matter of few hours. So obviously this is not ivabradine. So why the heart rate has gone up?
because of norepinephrine, sir.
The ivabradine, this is just a matter of few hours. I think that he has come from ER to your ICU, right?
Yes, sir.
So why the heart rate has gone up? Noradrenaline has been started.
Yes, sir.
Yes, sir.
Vasopressin.
Noradrenaline has been started.
Yes, sir.
Okay. The other thing is patient was almost, I think, crashing when he came. pH was so low. So there was
Yes,
probably
sir.
he was going to bradycardia, and you have given some fluids, you have ventilated him. So he has got some resuscitation. Okay.
Yes, sir.
Okay. Now you're coming to the echo. So echo 50% EF, mild generalized LV dysfunction, IVC 7 mm collapsed. So EF 50% is mild LV dysfunction. Do you classify EF 50% as mild LV dysfunction or normal?
50% is very normal.
Normal.
It is normal.
Normal.
Yes, sir.
But somebody has written mild generalized LV dysfunction, so they must have reported it like that, right?
Yes, sir.
So why do you think they have reported like that? The EF is 50%.
With such amount of tachycardia, it may be sometimes difficult to get the ejection fraction properly.
Okay, I agree. Anything else? There could be
So
diastolic
sepsis
dysfunction.
induced. Yes, sir. Sepsis induced diastolic dysfunction.
Yeah. So you are saying the patient has sepsis. Are you sure the patient has sepsis?
Yes, sir.
On what basis do you say the patient has sepsis?
So patient has organ dysfunction and there is a source of infection.
Why is this not hypovolemic shock? Patient has voluminous diarrhea for 7 days without intake replacement. Why this cannot be hypovolemic shock? What evidence do you have to support septic shock? Blood cultures are positive? No.
Blood cultures were not positive, sir.
Then,
Sir, the comprehensive GI panel grew organisms.
so that is there in infective diarrhea. That does not mean there is septic shock. Because there is volume loss. You understand? There is very significant volume loss. So how will you differentiate septic shock from hypovolemic shock here?
Septic
Paraphrase
shock
of
and by cardiac, sir, by cardiac index, we have to find out. That is cardiogenic shock, not septic shock.
No, there is no
Sir,
there is no cardiogenic shock.
by SVR, by sir.
How will you differentiate? Yes, you were saying something, Devajani. You were right. What are you saying?
So we have to look about the systemic venous resistance.
So how does that differentiate hypovolemic from septic shock?
In septic shock, the SVR is going to be dilated. The SVR is going to be low, but in hypovolemic shock, it will be high.
Very good. So do you have any SVR? Did you do cardiac monitoring?
So no, sir, we did not do cardiac monitoring this patient.
How do you what is the formula for SVR normally? How do you calculate it? How do you calculate SVR? No, if you have a flow track, then it is displayed, or any kind of
Yes,
cardiac monitor. But what is the formula? You can calculate it with the echo also. What is the formula? Simple formula. What is the relationship between blood pressure, cardiac output, and SVR?
cardiac.
MAP minus CVP divided by cardiac output into 80. Like that.
Again, Parvinta, say clearly.
MAP minus CVP divided by cardiac output into 80. It was the formula. I just remember.
MAP minus CVP
divided by cardiac output.
MAP minus CVP divided by cardiac output is equal to SVR.
Yes, sir. SVR.
See, the formula is very simple. Blood pressure is equal to flow into resistance for any tube, any system, whether it's the ventilator, whether it's the cardiovascular system. Flow is equal to pressure into resistance. Remember that. Whether it's the portal pressure, whether it's the airways, whether it's the cardiovascular system. So flow is cardiac output, pressure is your mean arterial pressure, and resistance is your SVR. So you get cardiac output divided by, sorry, one sec. What did I say? Pressure, sorry, I think I said that wrong. Pressure is equal to flow into resistance. So pressure, your mean arterial pressure divided by your cardiac output is equal to resistance. Mean arterial pressure divided by cardiac output is equal to systemic vascular resistance. CVP is ignored because it is a very low number compared to your mean arterial pressure. So that is the formula. So you can calculate the cardiac output using the VTI. Stroke volume can be calculated from the echo.
Yes.
And mean arterial pressure, you know, with the arterial line.
Yes,
So you can actually calculate the SVR. What is
Yes,
normal SVR?
1600 dynes per centimeter to the power 5 per second.
No, in numbers, what is normal SVR? That is very high, Dr. Devasis. It is not so much.
Sir, 800 to 1200 dynes per centimeter to the power 5 by second.
Very good. It is around 1000, approximately 1000.
Yes,
So anything less than 700, 800 is low.
Hmm.
So if you do not have SVR, calculations. You're not calculated. Huh?
Hmm.
Can you make out from the blood pressure itself whether there is hypovolemic shock or septic shock?
So by the
Yes, sir.
diastolic,
By diastolic blood pressure.
by
What will you
diastolic
see?
blood
What will you
pressure.
see in the diastolic pressure?
In septic
By
shock, the
by-
diastolic blood pressure will be low, very low.
In what? In septic shock or hypovolemic shock?
Septic shock.
Very good. So here your opening pressure is 80 by 40. Huh?
Hmm.
Your opening pressure is 80 by 40.
Hmm.
So 40 is a very low diastolic pressure.
Yes, sir.
So
Yes,
any
sir.
pressure less than 50, huh? Any diastolic pressure less than 50 is almost highly indicative of a vasodilatory shock.
Yes, sir.
So what are the causes of vasodilatory shock apart from septic shock?
Anaphylactic.
So anaphylactic.
Anaphylactic.
Anaphylactic, very good. What else? And you have neurogenic,
Neurogenic shock.
spinal
Yes,
cord
sir.
dysfunction.
Yes, sir. Yes,
And even adrenal sufficiency has low SVR, vasodilatory.
Hmm.
So we cannot discount adrenal crisis here because, you know, he was on steroids and his steroids dose has not been increased. Okay.
Okay, sir.
So we move on now. So IVC 7 millimeters collapsed. What does that indicate?
Volume depletion.
Intravascular volume depletion.
Yes, Dr. Devasis, I agree. Certain poisonings can also cause vasodilatory shock. I agree with that. So IVC 7 mm collapsed. So that means the patient is severely dehydrated.
Hmm.
Yes,
Huh?
sir.
Yes, sir.
This is on the ventilator.
Yes, sir.
Yes, sir.
On ventilation.
So can you use the IVC in a spontaneously breathing patient?
Yes, sir.
Yes, sir.
You cannot use the IVC in a spontaneously breathing patient. It has a very low predictive value. Only extremes of values can be used. Okay, either it is totally collapsing or totally dilated. Then only you can use it. Huh?
Yes.
And on the ventilator, it is much better. On the ventilator, it is much
Sensitivity.
better.
Yes,
Huh?
sir.
Hmm.
Now, does the size of the IVC has any relationship to the on the BMI? Is the IVC size related to the BMI or all patients have the same size of IVC? You know, we talk about size of IVC when we talk about volume sufficiency. So you see, this study was conducted from Kerala. They looked at the IVCs of a large segment of the population, and IVC correlates with BMI.
Okay, sir.
A patient who is around, at mainly the height. So a patient who's around 165 centimeter tall normally has an IVC size of 1.5 centimeter. And very few patients have IVC less than 1 centimeter or more than 2.2 centimeter. And there's a wide variation in terms of collapsibility. Okay. So in a spontaneously breathing patient, it is not good enough. Only extremes are predictive of volume status. On the ventilator, it is a little better when the patient is sedated and paralyzed. The
Okay, sir.
sensitivity and specificity is around 70% on the ventilator. Okay.
Okay,
So
sir.
here it is 7 mm collapse. So this is indicative of a volume deficient state.
Yes, sir.
So you can give fluids there.
Hmm.
How else can you assess for fluid responsiveness? The patient is the arterial line, patient is sedated on the
So
ventilator.
pulse pressure variation, stroke volume variation.
Okay, very good. So pulse pressure variation, stroke. So what is the criteria for pulse pressure variation and stroke volume variation?
Sir, in a mechanically ventilated patient, we see the stroke volume variation is more than 10% or pulse pressure variation is more than 12%, then we think that the patient should be fluid responsive.
No, but what are the criteria?
Sir, patient should not be spontaneously breathing. Tidal volume 8 ml per kg should be there. Low
How
lung.
much? How much time?
Sir, 8 ml per kg.
Okay.
And open thorax is not contraindication. Patient has no arrhythmia.
Okay.
That,
Okay. Okay. Is the application of PEEP a contraindication?
no, no, sir.
Okay. Correct. So I agree with that. Now you come to the CRT of greater than 5 seconds, no mottling.
Hmm.
So the CRT measurement has come into vogue after which study?
Andromeda shock trial, sir.
Okay. So what did this Andromeda study show?
Sir,
So
it's
the correlation between lactate and capillary refill time to see the tissue perfusion, and there was not much difference. Capillary refill time is a bedside method which can correlate with the hemodynamic perfusion without checking lactate frequently.
So what was the result of the study? No, when you read the study, the result. What is the result of the study? In 2 lines. What is the main outcome of the study?
Sir, capillary refill time can be used as a surrogate of can be used as a measure of perfusion instead of lactate. We can use that.
Okay. Is it better than lactate or same?
Similar efficacy, sir.
So that is not totally correct. It was shown in the study that it did not reach statistical significance in terms of being better overall. However, at 72 hours, the SOFA scores were better with the use of CRT
Okay, sir.
as compared to lactate. SOFA scores were better,
Better.
and there was less use of fluids at 8 hours. So that was the main result. So it is not only non-inferior, it is slightly better as per the study.
Okay,
Huh?
sir.
So that was what the, you should know this. This is a very important study, Andromeda study. Okay, so that was it, and it is the beauty of this is that it is not expensive and can be done easily at the bedside. You don't have to investigate the patient, don't have to do repeated ABGs, etc., etc. Huh? So apart from CRT and lactate, what are the other peripheral tissue markers you can use for assessing tissue perfusion?
PCO2, arteriovenous PCO2 gap is CVO2.
Very good.
morphine.
One is arterial PV's CO2 gap. Difference between
Yes.
venous and arterial gap. So, and anything else?
Sir, core peripheral and core temperature difference.
No, that is not there. Anything else?
Yes.
हाँ.
Sir,
आप भी हो कोई
SCBO2. Somebody has answered
SCBO2.
in the audience. You can use SCBO2.
Hmm.
So what are the values for PCO2 gap?
The PCO2 gap is more than 6 millimeter, then we should optimize cardiac output.
So it indicates low cardiac output, right?
Yes, sir. Yes,
PCO2
sir.
less than 6, more than 6, sorry. Huh?
More than 6, sir.
Yeah. Why it is used as more than 6? Because normal venous to arterial gap is less than 6.
Less than 6
Yes,
normally.
Huh?
Yes, sir.
Yes, sir.
Okay. So how does PCO2 gap help? Why is it so good? It is the most sensitive marker of tissue perfusion as such. Huh? So why? Why is it better than lactate and SCVO2? You see, what happens with PCO2 gap is that, you know, in sepsis, there's maldistribution and malflow in the capillaries. They can be shunting, etc. The oxygen may not reach the tissues despite there being adequate perfusion and may lead to lactate elevation. So sometimes lactate is fallacious, that we all know. But what happens with PCO2 is that PCO2 diffusion is much better than oxygen. So if there is malflow and maldistribution, AV shunting, the CO2 is still able to diffuse through. So CO2 is able to reach the circulation. So that is one. And second, when the cardiac output is low, it goes up. So because of these two reasons, it is a very good marker for low cardiac output state. That is the advantage of PCO2 gap. So out of
Okay,
all these markers, PC2 gap is the most accurate. But again, it requires you to do arterial sampling, venous sampling, and you cannot do repeated samplings. But one time or two times you can use it. Okay.
sir. Okay,
So
sir.
that is the concept behind it. Now, moving on to soda bicarb 200 milligram IV bolus. So any formula for soda bicarb administration deficit? What is the formula?
Sir, 0.4 into body weight into total 24 minus soda bicarb base deficit.
Very good. So 0.4 or 0.3, some people write 0.3, 0.4 into total body weight into base deficit. So that is the formula. But this corrects only if there's no further consumption of alkali. If there's ongoing consumption of alkali, you will have to keep replenishing it. This is just a rough formula. Okay, because this is only at that point in time, if there is no further acidosis. But acidosis is ongoing, so you have to keep correcting it. Now you have given 20 milliequivalents per hour by infusion pump, right? How do you normally give soda bicarb? How should you normally give? Should you give by infusion pump, or is there a better method?
Sir, we give isotonic sodium bicarb, sir.
Isotonic soda bicarb means what? How much sodium and how much bicarbonate is there in one ampule? Paramita?
Sir, in normal 7.4% usually available. Ampules are available 7.4%, and in oxy soda it is 8.4%
No,
soda
how
bicarb.
much in 50 in normal ampule that you have 50 ml? How much sodium is there and how much bicarbonate is there?
Around 15. Sir, in 20 ml, around 15 MEQ of bicarbonate is there.
So in 50 ml, there is 44 milliequivalents of sodium and 44 milliequivalents of bicarbonate. It is a highly concentrated ampule. Okay. So if you keep giving it by infusion pump, you end up getting hypernatremia. So ideally, you have to give in 5% dextrose.
Okay.
Yes, sir.
That reduces the tonicity and avoids the hypernatremia. That is the problem with prolonged soda bicarb infusions if you give with the infusion pump. So ideally, you should give with 5% dextrose. Okay. So we move on to the next slide.
The patient was fluid.
Some network issues.
Go back and then move it.
Sir, I'm trying. Network is slow and that's why it's not working. Sir, the slides are not moving actually.
It will move earlier also your question.
Yes. Yes, sir.
The patient was fluid responsive and tolerating. Hence, another 1000 ml bolus of NS was given, followed by maintenance of 100 ml per hour. Trias tube was inserted, continuous drainage was done, flatus tube inserted. IIP was measured, which was 11 millimeters of mercury. DVT prophylaxis with unfractionated heparin and GI prophylaxis with PPI was started. IV insulin infusion started to control hyperglycemia. All immunosuppressants were stopped.
Okay. So is there putting of flatus tube recommended? Whenever there is abdominal distension, is it recommended or is a practice which should not be done?
Ideally could not be done. There is chances of perforation.
Devanjana, is it okay to put? I mean, is it evidence-based, scientific or unscientific? Should a flattest tube be
Sir,
put or not?
so ideally should not be done, sir.
No, nothing like that. It can be put. If you think there is a lot of gaseous distension, it is recommended in gastroenterology. Okay, you can put the flattest tube. So IAP was measured 11 mm. What is the normal IAP?
5 to 7 millimeter mercury.
Huh?
5 to 7 millimeter mercury.
It is 0 to 6. Okay. And in obese patients, is it increased or is it same 0 to 6?
It should be increased.
So how much can it
It
be?
increases.
Up to?
So up to 10 is considered normal.
Okay, very good. So up to 10 to 12 it can be in obese patients. Huh? So you know that. Now rise tube drainage and DVT prophylaxis. Okay. So in the next slide.
So this was the lab report initially. Hemoglobin 12, total leukocyte count 18,000, platelet count 1,65,000, venous blood glucose was 358, urea 109, creatinine 5.5, sodium 133, potassium 2.3, chloride 105, bicarbonate 9, calcium 8.4, phosphate 6.9, magnesium 2, uric acid 12. Next slide, please. Total protein 4.7, albumin 3.2, globulin 1.5, bilirubin 0.3, SGOT is 12, SGPT 22, alkaline phosphatase 103, LDH 176, and procalcitonin was 5.9.
Carry on.
The comprehensive GI panel showed enteroaggregative E. coli, enterohemorrhagic E. coli, cryptosporidium, and the CMV PCR, which came back with very high numbers, 193425 copies per ml.
Okay. Next slide.
So this is the actual an image showing the CMV PCR value,
Next
which is
slide.
very high,
Yes.
193425.
Show the last slide. Last slide. Okay,
Which
CMV
shows a very
PCR
high
value.
value of CMV. And the next slide, which shows the comprehensive panel detecting the organisms enteroaggregative, enterohemorrhagic, enterotoxigenic, and cryptosporidium.
So it has done most of the pathogens. These are the pathogens which normally cause diarrhea.
Diarrhea.
You see,
Yes,
these
sir.
are very
Yes,
different
sir.
from the usual pathogens we talk about in sepsis. And
Yes, sir.
so this is very important. So next slide.
So this is the X-ray.
What is the
Initially,
comment on the X-ray? Wow, this is very poor quality. Can't make out anything. What was there in the X-ray?
sir, severe gastric the bowel loops dilatation was there, and and sir, there was no other opacities in the lungs.
This X-ray you can't make out much. This is a very small film, short, and you must have seen the X-ray. What was there? You don't remember. Okay, it is okay. Let it be then. This X-ray is very poor quality. All you can say is that the diaphragms are elevated.
Elevated.
Lung feet are very
Yes, sir.
small, so that may be because
And dilated gut loops.
yeah, there is some dilatation on the both the flanks, so it's possible, very difficult to say. There seems to be lucencies, and that is there. But that is better to be seen on CT. To comment on a chest X-ray about the loops is a little difficult. Either you should do abdominal X-ray. So what I can say is there is no infiltrate as such. Basis is very difficult to say because if the diaphragms are elevated, it is very difficult to comment on the basis. And even if you take an expiratory film, then the diaphragms are elevated. So there are many. So even if there is no abdominal distension, diaphragms will be elevated in a patient in whom you take an expiratory film. Okay. So what is the CT report of the abdomen?
So the CT report showed a dilated transverse colon, ascending colon, cecum, small bowel loops, and stomach with zone of transition in descending colon. There was suggestive of paralytic ileus, and there was normal graft kidney in right iliac fossa.
So the entire gut is dilated,
Dilated, yes, sir.
and the most likely cause is hypokalemia.
Hypokalemia, yes, sir.
And
Yes, sir.
any other cause? So the patient may be having non-occlusive mesenteric ischemia. Why he should get non-occlusive mesenteric ischemia is because you see these patients are atherosclerotic, right? He's diabetic, hypertensive, and even the lipids must have been high. So they have atherosclerosis in the mesenteric vessels. And when they go into hypertension, there's a low flow state in the mesenteric vessels. This is very common. There's a low flow state. So they
Okay.
don't go into frank mesenteric ischemia, but there is some degree of mesenteric ischemia. So this mesenteric ischemia also leads to bowel dilatation and ileus.
Okay, sir.
This is very common, especially in sepsis. Sepsis is low flow state, and elderly patients or patients like these who have diabetes, hypertension, long-standing, they have atherosclerosis. And atherosclerosis is there in the mesenteric vessels also. So when they have a low flow state in vessels which are atherosclerotic, they get ischemia in the gut, and that leads to paralytic ileus. And sometimes they bleed also. This is very common, huh?
Okay.
Okay. You must have seen also sometimes abdominal distension occurring in sepsis patients.
Yes,
Very
sir.
common, sir.
Next slide.
So
So
this
you
was the
can-
CT scan. Excuse me.
Okay, this is gross dilatation of the loops, huh? Bowels. Okay, next slide.
Surgical and gastromedicine opinion was taken. Injection ganciclovir was started as the for CMV treatment. Extracorporeal cytokine removal was done with HA330 filter for 6 hours. Tab nitazoxanide was 500 twice daily, and azithromycin 500 twice daily was started.
So hold on. So what is the current recommendation for cytokine removal in sepsis? Is it recommended?
So, in according to survival sepsis guideline, they have not recommended.
Very good. But what is the literature say? There are there are controversies. And what is the largest trial on cytokine removal? Do you know the name?
So, Euphrates.
Very good. So what did it show?
So, they have not shown any mortality benefit.
But there was a secondary analysis of the subgroup analysis. What did that show? Okay, that's very good. Pramita, you know what did the subgroup analysis show?
Sir, no, sir, no, sir.
Okay. So Samyogata, you want to say anything on cytokine removal?
Actually, it should not have been done. But since too many teams are involved, so we were all helpless, but we don't do it on a routine with our patients.
Okay. So you see,
We are very clear on that.
yeah, so cytokine removal is a controversial topic, and surviving sepsis guideline very clearly has as Dr. Debanjana has said, is not recommended. But nephrologists, in critical care like Dr. Ronco and Dr. Belomo, they have recommended in their literature. And the Euphrates trial conducted from 210 to 218, which is the largest trial, did not show an overall benefit. But in a subgroup analysis, secondary analysis, it was shown that in those patients with an endotoxin level of 0.6 to 0.9 units, there was a distinct benefit in terms of decreasing vasopressor dose and overall outcomes. And trials after that have shown that in those patients with a SOFA score of around 7 to 12, which correlates with the same amount of morbidity in the Euphrates trial, have a benefit. Okay. So these patients, if your labs are measuring endotoxin levels, and if it is between 0.6 to 0.9, or you can use the SOFA score of around 7 to 12, these patients are benefiting from cytokine removal. Either you can use cytosorb or polymyxin filter. And surviving sepsis guidelines is good for students and all. That's very good. You should know what the guidelines say. But there are a lot of controversies to the surviving sepsis guidelines. So that is the evidence behind cytokine removal. And why it is not universally effective is probably because when you have sepsis, you have pro-inflammatory as well as anti-inflammatory markers, and you have drug removal also in these filters. So we really don't know what all you are removing and how much of benefit you are getting in terms of removal, because so many things are getting removed. But that is what is the current take on cytokine removal. If you can measure endotoxin levels, or if you can use SOFA scores as some of the recent literature is stating.
Sir, any comments on using ulinastatin?
Ulinastatin has no role. anywhere in medicine, in critical care. It is a useless molecule and is promoted by pharmaceuticals. It has no role anywhere, even in pancreatitis. Okay, so why is nitazoxanide started?
Cryptosporidium was introduced.
Cryptosporidium.
Cryptosporidium, okay. And why is azithromycin started?
Sir, the patient had life-threatening infection, so we chose to start both nitazoxanide and azithromycin for cryptosporidium treatment.
No, but what pathogens are you suspecting for azithromycin?
So it was a treatment for cryptosporidium itself.
It covers cryptosporidosis, azithromycin.
Yes, sir.
I don't think so. Have you read this? Or you are
Sir,
assuming?
no, sir. Actually, nitazoxanide 500 twice daily was the initial treatment, and because the patient was life-threatening, azithromycin was
No, but what for organism is azithromycin started?
sir, for the coverage of cryptosporidium itself
Huh?
as an adjunct to nitazoxanide.
Okay, so
Nitazoxanide.
I'm not sure about this, whether azithromycin can be used for cryptosporidosis, but azithromycin, like I told you, is a go-to drug, first drug for GI diarrhea, because it covers a lot of organisms. Okay, so but those organisms are negative for PCR. So I really don't know why azithromycin is started. Probably it is used for cryptosporidosis as an add-on drug. I'm not aware of it. I've not read this. The only drug that works for cryptosporidosis is nitazoxanide, as far as I know. Huh? Okay. So what precautions should you take while starting azithromycin?
QTC.
Is there anything you should be careful about?
Sir, QTC prolongation.
Very good.
Prolongation.
So QTC has to be seen, and you have to be very careful in elderly, especially as renal failure. Okay, so QTC has to be seen when you give azithromycin. Okay. So, Dr. Samjogita, which severe symptoms?
So he came in with though it is debatable what was the exact cause of the shock, but he came in a state of shock. So considering it to be the source, this to be the source, we thought that it will be better. He's a already immunocompromised person. So we gave him a dual cover. So azithromycin for severe or recurrent cryptosporidium is recommended.
Okay, fair enough.
So
I did not
keeping
know
that
that.
in mind.
Okay, so azithromycin was given for cryptosporidosis. Okay.
Yes.
Next slide.
So, gradually the vasopressors were discontinued. Patients started making urine. By next day, all vasopressors were tapered off. The ABG showed the correction of the acidosis. Bicarbonate was on increasing trend. Patient was extubated to NIV as he had OSA with CPAP of 10 millimeters of water.
So, how many days he was in shock? Vasopressors went on for how long?
Sir, 2 days.
So, he's recovered very soon.
Yes, sir.
You know, with so much acidosis, he has recovered very fast. In less than 48 hours, his vasopressors have been tapered off and his sensorium has become normal.
Yes, sir.
So, you know, I have serious doubts with, though the diastolic pressure is 40, you know, that is indicative of septic shock normally, but he also had endocrine deficiency, adrenal insufficiency. So that can also lead to low diastolic pressures. I'm not sure whether this is septic shock. Because a patient with septic shock coming with a pH of 6.8 with the vasopressors getting tapered off in 36 hours is highly unusual.
So he got steroids also. Now he was started on hydrocortisone infusion.
Yeah, so that is what I'm saying. I feel that
Yes.
this was not septic shock. This was hypovolemic plus adrenal insufficiency. Because
Can be possibly, right.
yeah, because you know there is no. Did the cultures grow anything? Blood cultures? He did not
No.
receive any antibiotics.
No,
No,
blood
sir.
culture. There was no growth in blood culture, sir.
PCT is also only 5, right? It is not that high. PCT is only 5. So there is no real suggestion for septic shock here because he has responded rapidly just to volume replacement and steroids, right?
Yes, sir.
And you know, he has multiple infections going on. He has CME infection, he has cryptosporidosis, and he has this thing, what do you call, E. coli positivity. So I'm not sure that this is septic shock. Okay, next slide.
The patient then developed thrombocytopenia, for which the UFH and teicoplanin was discontinued. He required few more sessions of hemodialysis before his urine started coming. The diarrhea stopped. Patient tolerated clear oral fluids and was mobilized. He was transferred out of ICU to HDU. CMV, because the patient had thrombocytopenia, we consulted a hematologist who said that it could be a ganciclovir induced thrombocytopenia. So IVIG was given to treat CMV, but this ganciclovir was continued for 10 days, after which it was converted to valganciclovir.
So you see, if ganciclovir was causing thrombocytopenia, then thrombocytopenia would have worsened. Right?
So thrombocytopenia kept on occurring for around 4 or 5 more days.
Yeah, so it is not because of gans. How much was the platelet count?
So around 38,000, 48,000. It started decreasing. It went down to around 38,000. The lowest was around 30,000.
So one is ganciclovir, but if ganciclovir is causing and is continuing, it will fall further. What else? What else can cause thrombocytopenia?
Patient was on heparin.
So heparin causes
Hypertension, it was discontinued.
No, so heparin, if it causes thrombocytopenia, what is it called?
Heparin-induced thrombocytopenia, HIIT.
It is called HIT.
Heparin-induced,
Huh?
yes, sir.
Hit.
So how many types of HIT are there?
HIT 1 and HIT 2. So 2 types.
How do you diagnose?
Sir, there is a immune complex which forms in HIT 2.
How do you diagnose? How
So
do you
we send the
diagnose it?
HIIT panel.
You don't diagnose with Rotem. Sorry, Dr. Shinde. How do you diagnose HIT?
Hit panel. You should
We send a panel, just tell the name. What do we send?
HIIT panel. HIT panel.
You don't call it HIT. It's called HIT antibodies. You diagnose with HIT antibodies. Huh? And there's a serotonin release assay, which is not done anywhere. Serotonin is a advanced stage. Normally we do HIT antibodies. Huh?
Yes, sir.
So what happens in HIT? You get thrombocytopenia. What else happens?
Sir,
So Devanjana, what is the pathology in HIT?
so there is antibody which is created against this platelets, which causes immune mediated lysis of platelets.
Lysis. What is the pathology? What is the problem? One is thrombocytopenia. You have said that there is destruction of platelets. What else happens?
That both thrombosis and thrombocytopenia actually happen.
Okay, thrombosis. So you get thrombosis.
Yes, sir.
So you get arterial or venous or both thrombosis?
Arterial thrombosis, sir.
Thrombosis can occur anywhere, arterial or venous. Do you get bleeding in HIT? Very rarely you can get bleeding. Huh? So what is the treatment of HIT?
Stopping the heparin.
Heparin.
Anything else you have to do?
Protamine.
Any other drug therapy you have to give for HIT?
Protamine can be tried for reversal of heparin.
You don't add protamine.
Okay, sir.
So what do you give?
So what other anticoagulants you can give? He
You
says
have to use anticoagulation. You have, because there is risk of thrombosis. And even if thrombosis is not evident, he may be having thrombosis. So either you use fondaparinux or you have to use an IV direct thromboinhibitor like arcopetrin or pivalarudin. Okay. So normally you can use fondaparinux. Fondaparinux you can be used. Okay, Dr. Devanjani.
Sir.
Yeah. So now, any side effect of IVIG, you know, which is pertinent to this case? Side effect of IVIG.
Sir, the uses.
No, not uses.
The side effect for this patient.
Side
He has
effect.
an organ compromised already.
Sir, yes, sir. Kidney failure is there.
Yes,
So
IVIG
IVIG can cause kidney
can
impairment,
cause renal failure. Okay,
renal failure. Yes,
renal
sir.
failure one of the side effects apart from anaphylaxis. Okay, next slide.
So the reticulocyte count, LDH, uric acid, direct Coombs test, transferrin saturation, ferritin, vitamin B12, and folic acid was sent. Ganciclovir was changed to valganciclovir after 10 days of treatment. The urine output markedly improved. Patient did not require further hemodialysis. Visolon and tacrolimus was slowly restarted, and thrombocytopenia was improved, and subsequently he was discharged to home.
Okay. Now, what about the feeding?
So
How
after
long?
extubation, slowly the patient was started on feeds.
On which day was he started on feeding?
So by day 3, he was extubated on day. Sir, he was extubated on day 3, and by day 3, patient was started. So one. So I need to put the phone on charger. Can you excuse me for 1 minute?
Yes, yes, it's okay. Then I think you can put it there. I'll ask the Promita. It's okay. The Promita,
Yes, sir.
so can you feed a patient in shock?
If vasopressor requirement is in decreasing trend, we can start tropical feeding.
Okay, decreasing vasopressor or stable vasopressors and improving trend, you can start on this thing, NG feeds. Okay. Can you give TPN if you cannot give NG feeds in a patient in shock?
Sir, enteral feeding is always better than parenteral feeding. So, if first of all, we try to start enteral feeding always.
No, that is true. But if the patient is in shock, you cannot give enteral feeding like you said, okay? Unless he is on decreasing doses of vasopressor and improving or low doses of vasopressor. So in these situations, can you give TPN?
Uh,
So TPN also cannot be given. In a unstable patient in shock, neither can you give enteral nor you can give TPN. Huh? So
yes,
you have to wait for some time till the patient improves.
yes, sir.
So why you can't give enteral to a patient who's in shock?
Sir, absorption because splanchnic blood flow is low in shock. So absorption of the feed will be low, and it will cause more stasis and more chances of peritonitis and infection.
Not peritonitis and infection.
Actually,
But what
sir,
will happen? What happens if you feed a patient with shock? What are the studies shown? So you get mesenteric ischemia, you get diarrhea, you get vomiting, you get ileus.
yes, sir.
Huh? You get mesenteric ischemia.
Okay, sir.
Because when you feed the patient, the gut bowel cells, they want more blood flow for absorption and processing. While there is ischemia, so they go into mesenteric ischemia. Or they can be diarrhea because of malabsorption, or vomiting or paralytic ileus. That is what happens. That is what the studies have shown. If you feed a patient who is in shock. Huh?
Yes, sir.
Okay, and TPN, you cannot give TPN because there is complete metabolic disarray in shock at the cellular level. So that is the recommendation for feeding.
Okay, sir.
So I think that is about all. If you have any questions, Dr. Samyogita, you want to add anything?
No, it's okay. They need to really, it was a good session for them and for us. There were some points we were missing, I'm sure, like the pico planning thing we should not have done. We should have sent a stool culture. That is definitely we missed on that. But like all's well, that ends well. Patient got well.
You have managed really well. Your team has managed excellently. The
Yeah.
patient was almost arrested, He was 6.8 pH. This is
pH, he
more than
just-
this. So this was
somehow he survived.
uh,
And but yes, it was a learning experience. And I think they have learned a lot of things from you, sir.
Yes, sir.
thank you for presenting. Any questions, Debanjana? Any
So I
questions?
have a question. Is there a role of giving immunoglobulins for this CMV? Was it a life-threatening CMV infection that we gave him immunoglobulins, or should he have been left like that? on valganciclovir.
No, if the patient is not responding to ganciclovir, then you have to give, because he was already on prophylaxis. He was
Yeah,
already
but sir,
receiving.
what were the symptoms suggesting that this was the life-threatening issue?
Symptoms means he had a pH of 6.9. He had severe
No,
diarrhea.
sir, but they kept on attributing to the cryptosporodial diarrhea. So was it
No, no.
cryptosporidia or was it the
No,
CMV colitis?
this you have a very high CMV count. This is indicative of CMV viremia and CMV
Okay.
infection. Okay,
Okay,
this is
sir.
a very high PCR load for CMV. And
Okay.
patients who are immunocompromised are known to have this thing, what you call multiple infections. Okay.
So we should have treated CMV
Yes,
as well.
this
like you
was
said.
a triple infection. Even E. coli. This is pathogenic E. coli. So he's having E. coli as well as cryptosporidisis as well as CMV colitis, and all over the GI tract is distended till the gut.
This immunoglobulins were indicated.
Yes, because you see, immunoglobulins are secondary line, because what happens is first line is your ganciclovir, but he was already on prophylaxis.
Yes, he was already on prophylaxis at home.
There is no difference between ganciclovir and valganciclovir. That's the oral form, this is the IV form.
That's the IV form.
So
Right.
you wouldn't have responded. So you understand. The only thing is, if the absorption was not there, you have to give ganciclovir, but IVIG was indicated. It is a second line therapy. In fact, there is even CMV specific IVIG. There is even CMV specific IVIG.
But we gave the normal IVIG
Yeah.
we get.
Because we
And
don't
the
have it in
time,
India. These are advanced drugs and they're not available in our country. So IVIG you have to give. I think it was recommended. It's a costly medication, but I think it worked for him. And cryptosporidiosis, the other thing is, cryptosporidiosis does not lead to so much disease, so much of disability so soon. It is a relatively slow onset diarrhea, and it goes on and on. HIV is very common. Cryptosporidiosis in HIV. So
yeah.
So these are the things about diarrhea, because diarrhea is not common. Life-threatening diarrhea is not so common, but we see it every year. One or two patients who have very severe diarrhea and they don't respond sometimes. And you are presented immunocompromised. We see it in normal patients, and you don't. And biofire cannot be sent all the time. In fact, it has come into vogue even recently only. Earlier, it was not there. So now we can send biofire, but sometimes the cost issue comes into play because it's 15,000. And all patients can't afford it. And unless you get a etiology on the diarrhea, severe diarrhea, it becomes very difficult to treat. Like I just told you, the antibiotics are different, the pathogens are different, becomes difficult. And every season, one or two patients we lose with severe diarrhea. They don't respond. They just, keep having diarrhea and hypovolemia and worsening organ failure.
So when should we repeat a CMV count?
So CMV count
should be.
Yeah, so CMV count should ideally be repeated after around 2 weeks of therapy.
Okay.
Yeah.
So even if the patient is responding well, then also we repeat a count.
Yeah, you have to document a decrease in CMV count, just to follow up and make sure if possible. Because low degree of viremia is present in many patients. Low degree of viremia. Because around it has been seen that 30 to 40% of the patients have chronic CMV infection, and so it's just like HSV infection. So there are a lot of latent viral infections which kind of flare up on immunosuppressions.
Okay.
So Devanjana, any questions?
No, sir. Thank you, sir.
So Pramita, any questions?
Sir, thank you, sir.
So audience, any questions? So there's a question from Tejas. Sir, didn't it look like concomitant cardiorenal syndrome leading to false positive procal? So as far as I can make out, I don't know what you mean by cardiorenal syndrome here, because the cardiac involvement is not really there. It's mainly a renal syndrome. So if you want to clarify, you clarify that. And in renal failure, people say procal becomes high, but in procal is very little, the rise is very marginal. It does not rise so much. Procal in renal failure, the rise is minimal. It does not go up to 5, 10 and all. So in renal failure, if the procal is going up significantly, it is not because of renal failure, it is because of the etiology, the underlying disease. It is falsely believed that procal is significantly elevated in renal failure. There is a very minimal rise in renal failure. So a rise in procal should not be attributed to renal failure. Anything like more than 2, 3 is all because of disease, not because of renal failure. So some more message. Okay. Any more questions? So stop the share screen. Okay.
Okay. Thank you, sir.
Okay, I think we'll close it then. Thanks, Dr. Devanjana. Thank you so much. All the best for your exam. So thanks, Paramita. All the best for your career
Thank you,
exam.
sir.
And thank you so much, Dr. Samyogita, for making it possible in such a short period of time. Really
Thank you so
grateful,
much,
and
sir.
I hope everybody learned, and it was an enjoyable experience for everybody. And I thank Dr. Chandrashi sir. Please thank him from my side for
Yes, sir, sure,
making
sir.
it possible. So see you
So if
again.
possible, give one more opportunity to us. The other batch would also like to present, the junior
Yeah,
batch.
yeah, sure. We'll present again. Okay, no problem.
Okay.
Take a
Okay.
case of pulmonary embolism this time. Proper case of pulmonary embolism. Huh?
Okay.
Okay,
sure,
take care.
sir.
Bye. Let me know when you want to present it. No problem. Huh?
Okay. Sure,
So
sir.
take your
I'll ask
time.
the team and
Yeah,
present
yeah.
the
Take your
book.
time, and this time no hurry. Make it aram se.
Okay.
Bye bye.
Okay.
Thank you.
Bye-bye.
Thank you, sir.
Thank you.